Three, two, one.
KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group, thewaytomyheart.org, in partnership with Abbott. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kim McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Leg pain, leg cramps, cold feet, burning, tingling, even foot ulcers. If those symptoms are yours and you have been listening to this show for a while, you would think you have peripheral artery disease or restricted blood flow in your leg arteries due to plaque buildup. But if you don't have plaque buildup in your leg arteries and you still have restricted flow, what might it be? Well, over the next hour, we are going to answer your question and tell you the critical questions you need to ask your doctor to get the right diagnosis for you. We have Dr. Krishna Mannava. He is a doctor over in Ohio, and he is going to be joining us today, Dr. John Phillips, and we're going to be talking about a disease that might mimic peripheral artery disease. And I'm not going to tell everybody what it is as of yet. Got to stay tuned.
Can't wait. This is going to be a good cliffhanger.
Cliffhanger.
I love it. You know, that is well, so first of all, welcome everyone. Hope everybody's having a fantastic Saturday. Kim, I hope you're doing well. Krishna is a good friend and colleague, and I think this is the first time I've had we've done an interview and someone who's like literally down the street from me, I think. And so it's always nice to have that Ohio connection. But yeah, interesting topic. I think it's a little bit probably underdiagnosed. It's often seen in I'm not going to give it away, often seen in younger people who are more, athletic and stuff. So, and definitely as opposed to what I do as someone who works with needles and balloons and stents and things, requires a surgical intervention. Dr. Mannava is a vascular surgeon, so right in his wheelhouse. So it'll be a good conversation.
Mm-hmm. I think so. And you are on call, so you might pop in and pop out. You have some piggies you might need to save, or actually even full lives. I mean, usually, especially going into the 4th of July holiday, it is seriously, it is hot in so many different areas. They're talking out here in California, possible record-breaking temperatures, a lot to worry about. So I would imagine you might see some stroke patients and the like.
Well, yeah. So obviously, if it gets warm, we have to make sure folks who have underlying cardiovascular issues, particularly coronary artery disease, are well hydrated. When it's hot and humid out, the arteries kind of open up, They dilate, and people who are on blood pressure medications that we want to lower their blood pressure can then get exaggerations in that decrease in their blood pressure, which can cause acute coronary events and things of that nature, which is why, we caution people sometimes for, jumping in hot tubs and things of that nature. But yeah, we've already had one heart attack this morning, and hopefully he's doing well. Hopefully we don't have any more, but you never know what's going to happen at Riverside Hospital in Columbus, Ohio.
No, and especially during the summer when you're on call, it's one of those things where, yeah, you're on call, but you're actually going to be working because so many things happen during the hot weather that could lead to some sort of vascular or cardiovascular event for so many different reasons.
Yeah, and it's kind of interesting too, because folks are traveling. And so one of the gentlemen that we saw, he lives in Florida, he's visiting his son. He had a heart attack. The cute little old lady that I saw this morning who needs a little work on her legs. She actually lives someplace, I can't remember, it's fairly south of here, but was visiting her boys, and she broke her ankle and then was now having to rehab locally, and then developed an ulcer. And, it is what it is. At the end of the day, you try to take good care of folks and help them wherever they come from. And just like Dr. Mannava, we do a lot of work with folks with peripheral arterial disease. and some that don't have peripheral arterial disease that mimic symptoms of peripheral arterial disease, which we're going to touch on here real shortly.
You know, it's interesting because you're in the hospital, you have those on-call duties, and I'm curious with Dr. Mannava. Dr. Mannava, do you have on-call duties at a local hospital? You have your own office-based facility, and that's typically, well, 9 to 5 during the week, they claim, but you also, you know, have your call, you know, 24/7 call service in case one of your patients have any sort of complications that they need to discuss with you. But you don't have to actually do it for a regular hospital, do you as well, where you have to go in?
Yeah, so yeah, well, first, thanks, Kim, and thanks, John, for having me on. I really appreciate it. I've been looking forward to it. So this should be fun. Yeah, so I am a vascular surgeon. I do have my own private practice. I have my own freestanding uh, office-based lab and now a surgery center. But for years and years, I worked primarily out of a hospital. So I still have a connection, a strong connection to a local community hospital where I do take regular call with in the mix with a couple of other vascular surgeons. So yeah, so every third weekend and you know, essentially a third of the time I'm on call, but I'm on call every single day for my own practice and my
Yep.
patients. You know, unless I'm even, I mean, and you know, sometimes, John, even if you're on vacation, you still get called.
And that's where I was a little bit, you know, there was a little bit of sarcasm in there because people think that because you have your own private practice that you don't have any on-call duties. And I find CLI fighters such as yourself and such as John Phillips, and even if John was in a private practice, he would still be, just as you, taking calls 24/7. I mean, 7 days a week. You guys are
It,
really passionate about your patients.
well, it comes, I mean, we're wired a little bit the same way in that, yeah, you have ownership of your patients. You have such a good relationship with them and trusting their care to you. And then for you to hand that off to someone else who doesn't know your patient is difficult. And some of these people, I mean, as John knows, they've had numerous procedures over the years, and who better to kind of, if something were to happen. And then plus, you don't want someone like that landing on your lap if you've never met a patient. They've been taken care of by a quote unquote outpatient vascular specialist, and suddenly they show up in your ER. It's like, so yeah, it's you have to kind of figure it out. It can get complicated, but ultimately you do the right thing.
You know what's really nice though is I find with our circle of CLI fighters around the world is that even if a particular CLI fighter has a private practice, if they have a relationship with someone with another CLI fighter within the practice, I always find that the two call each other. And I even had heard that you both were on the phone this week, which was music to my ears as we were leading up to this show this week, where you both were going to be on for the first time together in an interview setting. But they'll call each other, and the person in the hospital says, hey, you know what, your patient just came through the emergency room. Anything that I need to know about this patient? And I think that that's fantastic. It's a definitely a patient-centric approach.
Well, let me just say this. Although, Kim, I've got a fantastic quote that I've been working on here, but nonetheless, we'll get to it. But I will just say this because I think it's important that we have a conversation with somebody who has a highly functioning office-based lab that now is going to be pivoting, and correct me if I'm not wrong, Christian, into a ambulatory surgical center, so he can do more procedures and things of that nature. But you know, the OBLs, as the acronym, have been maligned pretty heavily of late, and it's important for us to, I think, recognize ones that do a good job. And
Yeah.
I can speak from experience. Krishna does the right thing, and there are some out there that don't necessarily always do the right thing. And
Yep.
not to throw anybody under the bus, but I think it's important to, at some point during this conversation,
Ladies and gentlemen, boys and girls, we
Ask
got to
Kevin.
go to
But anyway,
commercial
we're going
break,
to
so
break.
you're going to hear more here on the Heart of Innovation on KDOW. We'll be back soon. Y'all look clear.
Did I miss the
I
chat?
love it.
Where's the
I
chat button?
love when you get cut off. That was so fun. I saw it. I totally saw it
I
coming.
couldn't see. I don't have my chat button up. I don't know where the chat was because I'm trying to find this quote. And then
Was the
I
best.
I was getting ready for a big compliment and then suddenly it got cut off. Damn
I know.
it.
I know I want y'all to have the time, but we got to do the thing and the place and the time. I feel like we are in some kind of storybook at this point.
Yeah. And you know what's really crazy? I've had two folks in our network of patients that have shared educational materials from two different centers that I know are two of those chains that in my experience have not been doing the right thing for patients. Too many procedures in not the right way, which is why they have so many procedures. And I feel bad because I don't like censoring people, but I also don't like, in a sense, bad mouthing particular people or anything. It's, whatever, but I have to delete those pieces of content. Some of these chains do a really good job. They spend a lot of money on marketing. And even, one of them has a great name that is perfect for marketing, that Douglas probably knows very well where he is located. And it's very frustrating to me because they see the educational content, which is their purpose. And then the patient's like, when it's shared, oh, they must be good because it's allowed in the network. So I have to be very careful and I have to remove content unfortunately, from some of
Everyone,
those
sorry to
that
interrupt. We
are
got
not
5 seconds
so good.
till we air.
Okay, John, you're starting, you're going to pay that compliment and
1220
give us
KDOW.
some inspiration.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. I was about to pay my friend and colleague, Dr. Mannava, a compliment before I was so rudely cut off by our wonderful producer, Colin. But as I was saying, it's important to recognize people that are doing it right in the office-based space, as well as now in the ambulatory surgical space, because these procedures that we do in the hospital can be done oftentimes for less as it pertains to cost for the patient and kind of general overhead. And if they're done correctly, patients have a fantastic experience. A lot of times folks that come to Riverside, great facility, but they get lost parking and this, that, and the other. So there is a convenience for the patient. And I hope that moving forward, our the societies that we work with and the physicians that do the procedures we can all kind of pull the rope in the same direction and kind of keep these places alive, as opposed to potentially having them close. Because I know, Kim, we've talked, there's some friends of ours and college people that they've had their office-based labs closed for various reasons. So at any rate.
And what's interesting in the particular case we're going to get to with the disease that we have yet to mention still, ... It was a situation where we had put this person in contact with a hospital and with an amazing CLI fighter, because I was thinking maybe the hospital, because they weren't sure, and there were some other things that made me think maybe a hospital might be better for this patient. But then the physician ended up getting, stuck in some politics and all this stuff. In meantime, based on the criteria I told this patient they should use in finding a doctor, lo and behold, this person went and found Dr. Mannava, and he was able to get this patient in literally right away, which shocked this patient. So before I connected right back with her, she had already had the issue taken care of for the most part. And I was like, whoa, it's just been days since I talked to you last. So there are these benefits to some of these other facilities that may not have the red tape that patients have to jump through, in order to get seen by the physician right away. And so for Krishna here, he was able to get this patient in right away, get the issue taken care of, and get this patient back on their feet and with some serious symptom relief right away.
Yeah, 100%. I mean, they're nimble enough, and at some point we'll let Krishna speak.
I know, we're having a great conversation about
If anyone's
Yeah.
still listening, we'll see. But no, yeah, I mean, they're nimble enough where they can get folks in the same day.
Yeah.
Just the way we're structured here, there's a call center and there's scheduling
Yeah.
that's centralized. And I mean, it's just an easier way to some degree for patients to get access. So I'm all for I'm all for an OBL when it's done appropriately and good care is taken of the patient, which Krishna does. So kudos.
Well, I
Fantastic. Well,
appreciate
we're gonna
that.
get to
Thank
him.
you,
Yeah.
guys.
We're just blowing you up right here.
Yeah, I know.
You don't even
I
have
don't
to
fit
say a
in the
thing.
Zoom camera anymore.
Well, John, we want to get to Dr. Um, Mannava in a moment, but you have some words of inspiration before we get into the heart of this discussion and tell everyone about that disease that we've been hinting about, that everyone should know about, that may seem rare, but I think it's more the case that it's just underdiagnosed. And there might be a lot of people out there suffering. So let's get to that soonest. So first, your words of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
All right. So let's see. We're coming up on the 4th of July, celebrating the birth of this wonderful country. Before we went on air, we were talking about, I caught a little bit about microbrews. And I think probably one of the oldest, it's now not really a microbrewer anymore, but it was at one time, Sam Adams, right? So I thought, all right, let me see if I can dovetail, right? The 4th of July, a freedom fighter, and then microbreweries. And so I got a quote from Sam Adams, which is kind of interesting. And I think that it really speaks to what the minority of us do in the sense of the passion for critical limb ischemia. And so Sam Adams is quoted as saying, "It does not take a majority to prevail, but rather an irate, tireless minority, keen on setting brush fires of freedom in the minds of men." Again, this is in the 1700s, but I like that quote. I think that's kind of fun. Like the minority can prevail if they're tireless and they just never stop. And that's kind of what, actually, Kim, that's what you do. You're tireless and you never stop. The Energizer Bunny.
Yeah, we even had an emergency call this morning, from a patient in Canada. And so it's one thing after another, after another, after another. And so we just continue the good fight. I don't know as many doctors, everyone knows in Canada, simply because they're not as they're not in the public as much, as we see in other countries, especially in the United States. So they're literally a little bit harder to get to personally. And I end up having to go through the call centers like everybody else. But I'm hoping, crossing my fingers, I did find one of these doctors in a particular area on LinkedIn, and I'm hoping that he will be kind enough to get back to me so we can get this patient the care that she needs and the directives that she needs in order to improve her symptoms. So
All right,
always
so
a good fight. Love that quote.
Are you gonna tell me what the diagnosis that this patient has?
I know. I know. We just keep you in the dark all the way up until it just makes it more fun with the free flow of the conversation. But I know that that Krishna here, who's with us, Dr. Mannava, he's also fighting the good fight, because it's also an uphill battle with him also trying to help a minority of patients, which actually are being underdiagnosed with something called, Dr. Mannava, do you wanna be the hero here?
Sure, sure. So the mystery diagnosis is popliteal artery entrapment syndrome, PAES.
So that's a
So
mouthful, Krishna. That's a mouthful. Tell our listeners what exactly that is and why it gets misdiagnosed so often.
Yeah, absolutely. So I'll try to keep this concise because we can talk a lot, dive really deep, but normally, patients present to us as vascular specialists with typical atherosclerosis, plaque buildup in their leg arteries. But when you have a unique type of patient, a younger patient typically, who presents with similar symptoms to patients who have typical peripheral arterial disease, but they're young, immediately you start, red flags start going off, or they should. And so popliteal entrapment syndrome is one of the diagnoses that should come to mind in younger folks. So what happens is the popliteal artery, the artery behind the knee, as people develop congenitally, typically the calf muscle, your gastroc muscle, the medial, the inside half of that muscle can develop typically before the artery, or after the artery. And if the artery develops after the muscles develop, the artery gets pushed to the side by the tendon of the calf muscle. And it doesn't come to being significant until typically people are a little bit older and more either usually more athletic or more active. And when that muscle grows, that artery gets more and more pushed to the side or deviated. And that repetitive trauma to the popliteal artery behind the knee can lead to damage to the artery, either externally or internally. It can lead to clots forming. It can lead to the artery totally closing off, clogging off, or it can lead to showering fragments of clot to the arteries lower down in the leg or foot. And so in some people, they can be asymptomatic with popliteal entrapment for their whole life. But in certain folks, that artery can get severely damaged and lead to a lot of very limb-threatening complications.
Hey there,
And we're
everyone.
going,
Dr. Krishna will be back here to tell you more about this disease here on the Heart of Innovation. You're listening here on KDAL. We appreciate your time. We have to go to commercial, but I promise you more of the good stuff will be there. So stay tuned.
awesome.
3 years ago, my symptoms started
Everyone's
with
clear on
leg
that side.
pain and leg cramps while walking.
Me
Thank
too,
you.
with a tightness in
And
my
so
calves.
we
Do you know, my
have
doctor thought
Angel
that
is
my
here.
leg
Hi,
cramps were a
Angel.
side effect of the statin he prescribed me.
Well, my doctor just brushed them off as another symptom of old.
Oops, there we go. Can you unmute?
There we go. Hello, how are you?
Hi, you might recognize this
Hi.
wonderful hero that's on here, Dr. Mannava.
Yes.
Sorry, Mannava. This, look, you can see the smile on John Phillips' face. He was because he loves the having the patient involved, so this is really exciting for him. We turned it into our Save My Piggies series. And so he gets really excited about that. So what I was thinking, and you guys, Dr. Mannava and Dr. Phillips, let me know if I'm completely cuckoo crazy here, but I was thinking that I would love for the doctor to guide her through kind of that journey as if he was doing the consult himself, like what her experience has been, because it's so interesting that he was the first one to actually figure this out. And when she called our hotline or came to us, it was like, I can't even walk. I have a knee scooter. Like I can't even walk on this foot, and these doctors are literally brushing me off. So,
Yeah,
Dr. Mannava,
that'd be great. We'll take it back because what I wanted to ask Krishna was, what's kind of who's a typical patient? Because if I look at Angel, and I'm going to make some assumptions here, but she looks pretty young to me, and so not a typical PAD player. And then we're looking for risk factors for PAD, and the patients that I've seen that have this are often young females who are athletic that then have these symptoms. And in fact, one of my partners, who's an electrophysiologist, his daughter had it, and she thrombosed, meaning the vessel closed, and she had acute limb ischemia as a track runner. And so I don't see these folks very often because it's a surgical fix, but most of these folks do have symptoms early on, because I don't know that I've seen one, someone in their like 50s or 60s that have it. But at any rate, yeah, I think that's a great way to do it. Let them have a conversation and a consult. Just make sure everybody's aware of the timing on the chat.
Yep, that would be amazing. So you're going to take us back because you want to ask them the question.
Yep. And then do you want to introduce Angel and then have them?
I actually think that it would actually be interesting, because I think the answer to your question would lead into him probably just bringing in his own patient.
Fair enough. Whatever works.
And Krishna, we only use first names in patients, even though Angel, do you want your name to be displayed fully, or do you want me to fix it?
No, you can display it fully. It's fine.
Okay.
All right, folks, we're going to be live in 5,
Okay.
4, 3, 2, 1, 0.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for staying with us. Before we went to break, we were discussing a diagnosis called Popliteal Entrapment Syndrome, and it's not technically peripheral arterial disease because you're not getting a buildup of kind of debris within the artery with risk factors to include diabetes or high blood pressure or high cholesterol. But this is just kind of the way you were made, so to speak, and over time you can damage that vessel. And so, Krishna, you did a fantastic job of explaining it. My question for you is, who's a typical patient? Because again, these folks typically don't have the risk factors that we look for, and therefore they may get kind of blown off as this isn't a vascular issue, it's fibromyalgia or leg cramps or something like that.
Yeah, it's a great question, and that's sort of the root of what differentiates popliteal entrapment from typical vascular disease is that it's really it comes from something totally different. So the patients we typically see are younger. Oftentimes, they're teenagers who are getting into athletics. So a typical classic example is a young 16, 17-year-old who's really training hard for a competitive sport, and their calf muscle has really grown rapidly, and that can trigger it or bring it out. So but we do see it in a little bit older, not older, but in people in their 30s, 40s, and 50s as well, for slightly different reasons. Maybe they're more active, maybe they're walking more. It's hard to say exactly, but overall, patients are younger, and oftentimes they don't have those risk factors that you mentioned. So they're not smokers, they're not diabetic, they don't have high cholesterol. So those are, all those things immediately should trigger a different thought process, for me anyway, on coming to a diagnosis when patients present with atypical symptoms and an atypical risk profile.
And you have a patient, we have a patient, one of your patients on right now. Angel, welcome to the show.
Thank you.
Great having you. Why don't the two of you kind of go over how, the diagnosis was made? First of all, as I Save My Piggies portion, I always like to kind of hear your side of the story and the frustrations that you had before you had an accurate diagnosis and ultimate treatment plan.
Yeah, Angel.
Yes.
Angel, it's thanks for coming on, and good seeing you, by the way. Long time no see. Yeah, why don't you start? I mean, you came and you reached out to us, and the story is really compelling. So, we'd love to hear it. I mean, it goes back several months. So
yeah, it started in October of 2023, and I started having some numbness in my toes. And then I had like a lump at the front of my ankle. And then, but the numbness and the cold and the lump never was at the same time. So I did make an appointment with my primary care doctor in November, the beginning of November. And she's like, well, maybe it's just rheumatology, something autoimmune. You need to make an appointment with the rheumatologist. So it kept getting worse and worse, where I was, and everyone kept saying Raynaud's. And I was like, if one more person says Raynaud's, I am going to explode. Because I have been seeing a neurologist, neuro spine doctor, I've seen rheumatology, I've seen physiatry, I've seen cardiology, I've seen vascular surgery. I went to the hospital because I have sores on my feet. I've seen podiatry. I've seen every specialty that you could possibly see. And everyone just kept going back to Raynaud's.
So real quick, do you have any medical problems?
No, the only thing that I've had a hip replacement on my right side. And had that when I was 35, and then I had a hip revision when I was 36 on the same side. But nothing significant on my left side. Like it just all of a sudden just started killing me. Like my foot would go, I could not walk 3 minutes without, it was my toes. They would go completely white. It was like, I kept telling people I have no blood flow going to my foot. Like, what is
exactly? So then let me ask you this then. So before you met Dr. Mannava, had anybody like done a real vascular exam on you to check your pulses at all, or no?
So yes, so I had seen vascular, never seen the actual vascular physician, was only the nurse practitioner. They couldn't feel my DP pulse. They couldn't feel the pulses at all. Barely got
them. This was normal?
Oh, yeah.
Okay.
And so finally I decided, because she was like, well, the NP CTA came back and they said that was normal.
They said that was normal?
Mm-hmm. The CTA. So that was read wrong.
Okay, I was gonna say,
yeah,
because I saw the blockage and I saw it. I'm not a clinician. I'm not a technician. Yeah. I saw it.
Yes.
In the images.
They said it was normal. And she's like, well, just come back and see the vascular surgeon, but you can't get into her until the end of July. And I said, no, wow. I can't do that. So I made an appointment with cardiology, and he was gracious enough to go ahead and do an angiogram. He did see that there was occlusions in my ankle. But he passed where he needed to go.
He went down. So he came down from the groin. So he poked in, in the groin, and he took wires, down, down your leg. Yes. And I don't understand. I have to have Dr. Mannava jump in. How do you miss that? Can you tell me from a doctor's person, how do you miss that going down? Because if he's going to see what's happening in the toes, doesn't he have to pass the knee first?
Yeah. So one, you have to have a little bit of suspicion, right? You have to kind of suspect this to really look at it. And then when you're doing an angiogram, you have to do some maneuvers, which they may have done, but you have to target a certain area, the popliteal artery, and you really have to make the maneuvers extreme to really bring out the compression or the entrapment. So it can be missed on an angiogram, and definitely in Angel's case specifically, the arteries look normal when she is at rest. So a CAT scan, it would look normal.
Oh. Wow.
Even though she has blockages down at the ankle or into the foot, the CAT scan is not good at picking those up typically. So that's
really
that's
why is that? That's interesting.
So as the flow is somewhat limited and there's blockages down that far down, CAT scans have some limitations, like especially if the blood flow is a little slow, the contrast wears out, and the arteries are smaller down at the ankle. So that's where CAT scans, MRIs sometimes can be limited to look that far down the leg.
It's interesting because there's so many doctors that I've talked to around the world that say that they literally trust their CT angiograms like 100%, and they will not take a patient and put them on the table for a diagnostic angiogram that could include possible treatment if they saw something.
I hate to be the villain. I'm interested in the conversation, but these commercials are itching up on our back. So you're listening to the Heart of Innovation here with Kim McNicholas, Dr. John, and Dr. Krishna. We will be back right after these messages.
Life is challenging.
Man, we don't listen very well, do we?
No, did I miss this one? Did I miss the 30 seconds? Yeah. 2:37.
I was so interested in this, and I was like,
Yeah. Well, it's a good
Here's
point
the
to
thing.
like
I like you guys a lot, so I'll give you leeway to the last minute. So it is my fault, but I do like what y'all talking about. So
Yeah, no, I am so Dr. Mannava, I mean
So
seriously.
I'm gonna try something. I don't know if I can screen share, but I'm going to flip it and see if I can show you guys Angel's angiogram. Can you see that?
Yeah.
it's light, but I can see the outline of the leg.
Yeah, I can see the foot.
And I'm going to show you what her ultrasound images look like if I can find it. I don't know if it'd be something you want me to show on this. Here's the ultrasound image of the artery being compressed.
Wow.
When she plantar flexes her foot.
I may have missed it. Did you do maneuvers during the?
Yeah, so right there,
CT?
she's plantar. Well, oh, during a CT. I mean, I didn't order a CT.
Oh, okay.
She had a CT in Dayton, I think.
Yes, it was in Dayton. And they didn't do any maneuvers during the CT.
Yeah, I mean, sometimes it'll show like the arteries patent, but yet that you may miss some of the muscle heads, I think. But at any rate.
So a CT can show you nice cross-sectional anatomy, and you may be able to pinpoint what's causing the compression of the artery or the entrapment, but it's not dynamic.
All right, guys.
Right?
Sorry to interrupt. We have about 3 seconds till we air.
Just make sure you
And
don't
here we go.
since we're on radio, just describe it.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We are in our Save My Piggies segment of the show, and we have Angel who's been with us. She's been kind enough to share her story. She has Popliteal Artery Entrapment Syndrome. It is a rare condition, but I think it's considered rare because it's underdiagnosed. And Dr. Mannava over in Ohio was able to diagnose her with it when all of the other doctors, including other vascular surgeons, cardiology, they all completely missed it. And before the break, he was getting into why it's misdiagnosed and how it was particularly missed in this case when she went and had what we consider the holy grail of diagnostics, which is the CT angiogram. So many doctors I know say, hey, I'm going to decide whether I treat or don't treat based on that. But it's not until with this particular situation, especially, that you go in for a diagnostic angiogram and use intravascular ultrasound, or IVUS, I think in this case. During the break, you were showing us the imaging that showed obvious compression that was happening, doctor.
Yeah, so great points. A CTA is a great test, but it's a static test. And this is a dynamic condition. So you need a dynamic test, in my opinion, to really demonstrate it. So one thing that we can do is a non-invasive ultrasound test. So you can measure the waveforms of the arteries in real time while you're doing maneuvers to flex the foot or extend the foot to see if you can change the waveforms in the arteries and bring out the popliteal entrapment. So that's the first thing we did in the office, right, Angel?
Yes.
That kind of gave us a little bit of a clue. And then we said,
Krishna, you must have had some clue that there was something going on based on the CT. Did you see the CT scan or no?
No.
So your physical exam led you to believe, or did you just say I was going to do an angiogram just because?
No, because the clinical suspicion she had, so we put it all together, right? It's the whole picture. It's a healthy, relatively healthy patient who's younger, who suddenly has lost pulses in her foot. They did a cardiac workup in Dayton, so she didn't have a cardiac source of a clot to her foot. So then it's like, okay, well, then we start the differential diagnoses start getting limited. And so popliteal entrapment really moved up the list quickly. So that's when we did the ultrasound, and then we said, look, we got to do an angiogram. And there may have been some mention along the way, right, Angel, that someone maybe suspected it could be an entrapment syndrome.
Yeah, but they thought the entrapment was at the ankle. They thought it was something to
Oh,
do with the ankle versus anything higher up.
no, that's interesting. Yeah. So I haven't seen entrapment there. But so anyway, so we scheduled it right away for an angiogram. And like Kim was saying, so we did a dynamic angiogram where we had her press really firmly against resistance. And that's where we could see the artery just completely pinching shut and no flow through to her popliteal artery. And then we did what's called an IVUS intravascular ultrasound, and it was pretty dramatic, one of the most dramatic ones I've ever seen, where the artery just gets completely flattened like a pancake when she planted her foot. So right there, the diagnosis. It's pretty obvious.
Well, and Angel, I would imagine that that was quite the experience, and a very different experience being on the table with this doctor versus other ones and having to move around.
Yeah, it was very interesting, and I just loved the excitement with Dr. Mannava when he was seeing it and he was showing people. He was like, "Oh, like it's right there, it's right there." Like he's like, I could see his brain working. And he was thinking like, this is what it is. Like he knew what it was, but when he seen it, it was like the excitement, and he was just like, there it is, right there. You want to see it? It was absolutely, it was an experience, and I'm like, I knew I was not crazy. And I think just trying being my advocate for myself, because everyone just kept saying pretty much, I just felt like I was crazy. And I'm like, no, there's something wrong. There's something wrong. Like, this is not normal. This just does not happen to a 43-year-old. It just does it all of a sudden. So I knew something was wrong. I knew it was there was blood constriction somewhere. But nobody was listening to me. So I really, really appreciate Dr. Mannava.
And I would imagine that they would be sending you to psychiatry for anxiety and stress. We have so many patients. You were sent.
Yes. Yes.
Oh, wow.
Mm-hmm. Yep.
Well, let's focus on something positive, right? So he makes the diagnosis, but let me ask you this from inquiring minds want to know as an interventionalist, were her tibial, or so were the tibial vessels, so the branch vessels below the knee, were those occluded? And so the theory was she thrombosed them because of the constriction?
So great question. So you can have popliteal entrapment without showering clots to your foot and just have symptoms based on the entrapment. Or then it gets more severe where you've had clots, the artery gets so chronically damaged, or the repetitive trauma to the artery leads to clot formation. Well, the artery's healthy, so the clot, it's not hard plaque, it's soft clot. It breaks off the artery. And in Angel's case, it lodged both in her DP and in her PT at the ankle. And she had somewhat of a underdeveloped perineal artery. So that's the reason she was having the ischemic symptoms in her foot, the color changes, the numbness, and things like that.
So how did you treat it? Because, and I'd love to hear Angel describe, the feeling of, having this situation fixed.
Dr. Mannava, which I don't know exactly which artery you had unclogged, but when he was in there doing the angiogram, I could feel the blood go through my foot. It was like a shower of blood finally being able to get through my foot. And I mean, it hurt at first, but they were like, well, it's because you haven't had blood in that area for some time. So yeah, one of them I think is still clogged up, and he's going to have to fix that somehow once he does the surgery for the entrapment. But yeah, it was very interesting. It was so great. I came home and I was like, I can go to Kroger. I was like, I can walk in the store.
Well, coming up right here on the Heart of Innovation, we're going to find out exactly what the doctor did to fix it and how you can check with your doctor to find out if this is something that is ailing you. So stay tuned right here on the Heart of Innovation. Don't go away.
Okay, 1 minute and then we're back.
Okay, we only have 4 minutes in this, so we got to go fast. Watch the clock, please.
I'm going to show you. Here's her image for you
Dr.
guys.
Phillips, take us back in to get us right into the solution.
Yep.
Can you see
Oh,
that?
yeah, I can
Okay,
see it.
also on that note, guys, for this last segment, I don't control when the music goes off. So when you hear it, that is 30 seconds exactly for the like disclaimers and everything of the sort.
Okay.
Sure.
Oh,
Dr.
geez. Okay, I'll go quick.
Mannava, yeah. Yeah, we want to see the results. They can't see it on the radio, but we can see it on the internet. So
Yeah. So
There it
there's
is.
the static image. Oops. Here's some of
All
the
right, folks, we're going
flow
to be
down
live in
to her foot
5,
when we got done with it.
4, 3, 2, 1, 0.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
All right, everybody, we are rounding third on this show, and excellent Save My Piggies. Thanks to Angel and Dr. Mannava for joining us. So before we went to break, Krishna, you had diagnosed the entrapment on the angiogram. You found out that several of the arteries below the knee into the foot were blocked. Sounds like you were able to kind of get through one of them, open that up. But at the end of the day, this is you have to release the muscle, right? You've got to do a surgical procedure to kind of allow the artery to breathe, so to speak, correct?
Exactly. So we made the diagnosis pretty quickly. And in Angel's case, I said, Angel, look, I'm going to go for it and try and get at least one of your arteries open into the foot to at least get you some symptom relief. But you have to remember, these clots down in the foot have been packed in for a long time, months. And so they're not easy to just suck out or extract. So, and sometimes you can make things worse when you are quote unquote mucking around down in the ankle. So anyway, so we took the chance, and it was a little painful, it was a little touch and go, but we were able to get her posterior tibial artery open and into the foot, and so that immediately gave her some symptom relief. We're going to schedule her for the popliteal entrapment release surgery, which is about a 90-minute surgery typically, where we go in behind the knee surgically, find the area that's entrapped, and release. Typically, if it's the medial head of the gastrocnemius muscle, release that, and then it frees the artery up. In some folks, hopefully it doesn't look like in Angel's case, her artery is healthy, so we don't have to do a reconstruction or a bypass of the artery, which makes it way simpler. In some folks I've treated, I've actually had to bypass the clogged popliteal artery, and that adds a couple hours to the surgery. But it can all usually be done through an incision behind the knee.
And is this something that there's some long-term durability? She won't have other problems down the road, or what can she expect?
No, it's amazing. So this is one of the few things we can treat that typically has amazing durability and can last her whole life, and prevent her from having this.
Basically cure from it, right?
Yeah. And how often do we get that?
Yeah.
I know.
Never.
And Angel, how are you feeling now? And what's your best advice for other patients that are in your situation?
Just be an advocate for yourself, because I mean, so many people, so many doctors were just, I mean, I had people the physicians, as soon as they'd be like, I don't know. I don't know. Like, wow, I've never seen this before. And there was probably 5, 6. I was admitted into the hospital for almost a week. And the vascular surgeon came in and said, oh, well, you don't have a pedal arch. And I'm like, I don't know what that means. And then I never seen a surgeon again. I was like, I have no clue.
Well, but so let me ask you, do you have normal pulses on the left? Which was the leg? The right leg was affected?
The left was affected.
Yeah.
The left was affected. Do you have normal pulses on the right?
So there's some sort of occlusion on my right too, but I don't have any symptoms.
Huh.
Yeah, I mean, I can
strange.
palpate her pulses, both pulses on the right, John.
Oh, okay.
Yeah.
I mean, so like we talk about real quick, we talk about how simple the diagnosis could have been made very simply if you just examine the patient. And that's what we tell to our, doctors in training. Examine the
Yes.
patient. They will tell you what's wrong with them. That's why this is like
100%.
mind-numbingly. I'm glad you got to the right guy, though. That's good.
I know, I am too. I'm so thankful.
Yeah, and doctor, I'm curious, why would she have? That's interesting because if it's just popliteal artery entrapment syndrome, why would she have it? Is there any issue? Have you looked into what's going on with the right leg as well? If she has some sort of occlusion
No.
down there as well?
She doesn't yet, but she has a risk of having popliteal entrapment on the right leg as well. So it's something we'll study in the future. It's not causing any problems now, but if she does have significant entrapment, it might be something that needs treated prophylactically.
Yep.
And this is something that, again, like peripheral artery disease, you don't want to treat it too soon. You want to make sure that because it is something that it does take a lot to go in there, and surgery is involved. And anytime surgery is involved, there's greater risks. So you don't want to treat that too soon unless they do have those debilitating symptoms. Is that right?
As we're wrapping things up, what kind of medications do you have her on?
Angel already came to me on a blood thinner, on a full anticoagulant. So I've continued that because I don't want to risk clot forming until she has the surgery. Once she has the surgery, she shouldn't really need more than probably a platelet blocker.
And that too is a bit of a head
You've been
scratcher.
listening to The Heart of Innovation with Emmy Award-winning journalist.
Thanks for joining us, everybody.
And interventional cardiologist, Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education.
I guess we're clear, but I'm curious. So it is one of those things, right? I didn't hear your answer. I don't know if I froze. But is it something that they have to you don't want to treat it too soon until they have those debilitating symptoms, right?
Well, no, not necessarily. In this specific case, if you've diagnosed it as a popliteal entrapment, they have already had issues with one leg. And if they have significant entrapment on the other leg, the asymptomatic leg, in only the 6-7 cases I've done, I'll go ahead and treat the other leg because you don't want to take a chance of clot forming and getting into a limb-threatening situation in this.
Yeah, that's why I was concerned about her one clot in the other leg, in her right leg.
I've got to go see a consult, but I just want to say one thing. Like, it's mind-numbing that they put her on blood thinners, so they assume that like there was some clot that had formed, but yet maybe I'm missing it, but they didn't like go to take that next step. Like, where did it come from? What's going on? So
nope. All they said was you need to be on Eliquis for the rest of your life. Have a great day. That's pretty much what they said.
Again,
I know, John. I'm with you. I the same thought in my head.
I love it. Well, hey, thanks everybody. I got to run. Krishna, we'll be in touch. Obviously, Angel, pleasure meeting you. Jim, fantastic job.
Nice meeting you as well.
Hi, everybody. Cheers.
Have a good weekend. Dr. Mannava, do you mind sticking around for just a few more minutes?
Absolutely, sure thing.
Because I see
John.
some questions that are coming in, and I wanted to let Angel, because it's surreal for me, and I have so many doctors when I tell them what comes to me, not only in the United States, but also in Europe and also in Canada, especially. I see this all the time, that these patients just get brushed off and they're told, just go home, take your medication, and we'll see you maybe in a year, if at all. And we even had one doctor from a hospital in Maryland tell one of my patients, who I think is on here right now, and she actually told 2 of our patients the same thing in a matter of just weeks, which was interesting. But she told my patient, and Deborah, you're on here, you're not sick enough to see me or any of my surgeons. And it was just like, oh my gosh. And she is presenting with some similar symptoms as Angel. Yeah. Which is absolutely crazy. And oh my goodness, Angel, this is probably music to your ears that you have this blood flow. You heard the whooshing sound during your procedure, and you're going to be there to raise your baby. Look at this. What do we have here?
This is my granddaughter. This is Shelby.
Oh my goodness. You're a grandma and you are 43 years old. Good for
Yep.
you.
Yep.
So you get to see your grandbabies grow
Yes.
up.
Yeah, and
That's
that's
amazing.
the big thing. Like I have cried and cried and cried because she looks down at my foot and she goes boo boo because I still have the ulcers on them. And I can't chase her and she wants me to chase and play with her. And I mean, it just breaks my heart. And that's what I kept trying to tell all the doctors. I'm like, I can't do everyday things. I can't wash dishes. I can't do laundry. I can't mow the yard. I can't play with my grandkids. I can't do any of that kind of stuff. And everyone still just kind of like blew me off. So I'm so excited to get all this done.
Isn't that amazing, Dr. Mannava, to see someone's life change like this? I mean, just from sitting and listening and being that one hero in her life.
It is. It is. I mean, it's frustrating a lot of what we do, Kim. Like we treat patients and they keep smoking or their disease comes back and back and back. But there are a handful of things we can treat as doctors, as surgeons, that a patient is cured completely and it impacts 40, 50, 60 years of their life ahead of them. And this is one of them. So it's really, when we get this, it's a pretty special thing.
That's amazing. And we have, I was mentioning Deborah. Deborah, did you want to unmute and run your symptoms by the doctor? Deborah is going in on Tuesday and actually going to, they may, I think, go up the foot. Deborah, what are your symptoms and are you hearing anything that resonates with you?
Yeah, exactly. My symptomatology started with ischemic toes and then pain and coldness in my foot. My left foot is colder than the right foot.
Yep.
Now I have got faint pulses, but I also have severe rest pain. I don't even have to be up to have pain.
Deborah, have you had any testing yet?
I did. I had testing done, and I think I just lost you guys. I had testing done. I was told my ABIs were normal, and that I had Raynaud's disease and nothing else, which I know was not correct. And then I had the CT scan done with contrast, and that showed no outflow past the knee.
Yeah. If you don't mind me asking, Deborah, are you diabetic?
No, I'm not
No.
diabetic. My lipids are all within normal limits. I'm not
Oh, wow.
hypertensive. I haven't
Oh, wow.
smoked in 50 years.
Oh,
And I'm a
wow.
nurse practitioner on top of it.
Oh, you're unlucky if you're a nurse practitioner or healthcare provider.
Yeah.
No, but seriously though, I think an angiogram sounds like it's the right next step for you. I mean, that's what I would do because especially if it's those arteries lower down, there might be something that we can fix to restore that flow.
Yeah,
Well,
she was
that's
saying that she has some microvascular disease in the heart, and they're calling it microvascular disease, in her case for the legs as well. And curious if you've heard that sort of, terminology used in a case like this. And would you consider it or classify it as peripheral artery disease?
It sounds like peripheral artery disease to me. How old are you, Deborah, if you don't mind me asking?
I've gotten a whole lot older, 70.
Oh, wow. I didn't expect that. So, no, but, having popliteal entrapment is a possibility, but unlikely, just based on age. But it doesn't mean you don't have blockages in your arteries very far down the leg. And I would never say microvascular disease until I've done an angiogram and really, really look closely at the foot.
I was told that it was microvascular disease many years ago because I had an MI during open heart surgery. I then had a stroke, and then all this develops.
Yeah, I'm not really sure how they can say that based on that.
this was an interventional cardiologist, but you got to remember this was quite some time ago.
Mhm. But it's so interesting that she goes to a large hospital. She's starting to have, some skin breakage, down between her toes. And, she can't even be on her foot. Her foot, she just messaged me the other day and she says, Kim, I can't wait, another 2 weeks before I have something done. I literally cannot stand up on my foot. There's just absolutely no way. So thank goodness I was on speed dial with this other doctor that we got her a second opinion with, and he had a cancellation. And so we kind of went around the schedulers and he just pushed her right through to take that cancellation spot on Tuesday. So he's going to go in. I think he's going to take a pedal approach and come up. And I know I don't want to say his name on here. I know you know him well. But it's going to be interesting to see what they find. But this other doctor at a large hospital, I mean, for them to tell a patient like this because they don't fit into a specific trial. It was a trial for microvascular disease, right? That they were doing?
It was. And then I had also seen, before coming to you, Kim, I had seen 4 other vascular surgeons, one of which said that he was endovascular, and they just shrugged their shoulders at me and said, have a nice weekend. And my toe
what did they do to
looked like an
explain the
eggplant.
pain?
I'm sorry?
How did they explain your symptoms?
They didn't. They just shrugged their shoulders. And my toe, the second and third toe are as purple as your shirt.
Oh, wow.
Yeah, I mean, you're breaking my heart, Deborah. I'm glad you found someone to take care of you.
It was only through Kim and her program that I found somebody. I had been in academic medical center for a long time and thought that was my best bet, but saw 4 people there.
Academic centers can be great and fantastic, but you really have to have, a CLI fighter. You have to have someone who just is relentless in trying to figure out what it is and whether it can truly be fixed. And you've got rest pain, you've got what seems like significant ischemia. I mean, I don't know.
There still are so many doctors out there that there's still so many doctors out there. And I think the issues that in both cases that they're having is that there are still so many doctors out there that don't think that you should be treating at all below the knee or the foot. So anything that happens below the knee or the foot, they say, well, when your pain gets bad enough, just come back and we'll just take it off without any sort of diagnosis for what's happening to them. No advanced investigational diagnostics being done. And, more than 30% of people who've come to our Leg Saver hotline with the Global PAD Association have not even been diagnosed with PAD prior to being told that amputation is their next option. And that's disconcerting. And that's really the direction that Deborah was going. And I think in Angel's case, I'm not sure if amputation was ever mentioned. I'd be curious to hear, but I know in Deborah's case that it was mentioned. Just basically go away. When your pain's bad enough, we'll just take it off with no explanation and no attempt to restore any sort of blood flow.
No. And as I said, I'd been to 4 vascular physicians at this facility, both surgeon and vascular medicine. And they just shrugged their shoulders and said, have a nice weekend.
It's amazing that the doctors just let you go with that excruciating pain, that feeling. And for people who've never had restricted, blood flow, imagine having that tourniquet. You get the tourniquet on your arm when you go get your blood work. Now imagine leaving that tourniquet on, except on your legs, as you're trying to walk, trying to even get out of bed, trying to sleep at night, right?
Mm-hmm.
Angel, is that a good description?
Yeah,
that's a good description.
It really is amazing to me how, like you said, that the doctors, they're like, it's in your lower leg and your foot, go away. I had a PA at the hospital I went to. Once I got admitted, she came in, she was through vascular surgery, and she 100% looked at me and said, why did you come here for this and call us down here? That's your foot. We don't work on your feet. We're vascular. And I was just like, I was mind blown. I was like, have you read my chart? Yeah. She's like, that's your foot. It has nothing to do with us. And she's like, I'll see what I can do. And never came back, but then they admitted me. So yeah, as soon as they see that it's your foot, they're just like, we want to have nothing to do with it.
Yeah.
They'd rather me have my foot cut off eventually, lose toes. And I absolutely could have.
Well, that's what they were suggesting to me. Yeah. They were suggesting the same to me, that you're going to end up losing your foot, and that was the end of it.
Yep.
But why?
And
why are
I'm
you
sure
going to lose your foot? What was
said.
the reasoning they gave?
I'm sorry?
Why were you going to lose your foot? What was the reasoning they gave? I mean, if you didn't fit into their microvascular trial, then what was the reasoning they gave for you ending up without a foot?
Well, they told me I didn't make the trial because my toe pressure was not bad and my ABIs were, quote, normal, which baffled me. How can you have normal ABIs with a vascular problem, an active vascular problem, and acute limb ischemia?
I mean, Dr. Mannava, I mean, hearing what they're saying, it has to be disconcerting. I mean, it just goes to my point that we have way too many doctors that if there are problems with the foot, vascular issues with the foot, it's almost like see no evil, hear no evil. We're not even going to acknowledge it. And that's what happened to Angel, that PA saying, hey, we're vascular. This is a foot problem. We don't treat that. And in many cases, there are departments that do not. They won't even acknowledge problem below the knee. And more than 85, I think it's 80 to 85% of people that have come our way on our Leg Saver hotline that have been on deck for amputation, a doctor never even attempted to open up arteries or restore blood flow, whether endovascular or bypass, in the year prior. And a lot of those actually they would treat to the knee, but then they would tell the patients, well, there's nothing more we could do, without even saying, well, we just can't treat, below the knee and into the foot. Some of them did, but some other ones would just say, well, we're done. We couldn't do anything more for you. Next step, amputation.
Well, Kim, as you know, that unless you know how to research, you're really left out there in the dark. Because had I not been able to research and find out that there was a procedure called a loop procedure, I would have never known what to do.
She actually got a hold of Dr. Marco Manzi in Italy, world-renowned, one of the pioneers in endovascular, and got in touch with him, which I was actually impressed with.
Wow. That's
she found
amazing.
him online and just messaged him. And, Marco, I mean, he's just the kindest soul, so passionate about what he does, as you are. And he just messaged the patient, didn't question why she was doing, just messaged her right back.
That's
but
amazing.
I'm also not the typical patient. Most people will not figure out how to do that.
Yeah, that's sad.
No.
And it's sad because you miss treatment then.
I will say this, Deborah, and Kim, treating the arteries that far down the leg, definitely the stakes are higher. So you have to have the right training. You have to have the right passion and mindset to go up, and you have to have the right judgment to know which are the right patients to go down there and open those arteries. So it's a combination of all that. And unfortunately, it's a minority of vascular specialists across all specialties
all of them,
that have that combination of all of that, the judgment and the technical skills.
Yeah, it's just a question of, getting the ones that don't have the skills the willingness to give up the patient to someone who can. I mean, we refer to different specialties all the time when we aren't familiar with something, or we think there's someone with a different set of skills that could do something, but for some reason when it comes to these patients, there's this resistance and hesitance and reluctance to giving up the patient to someone who might be able to have a different skill set, a more advanced training, and a passion and commitment to have, and patience to opening up these smaller vessels below the knee and into the foot in cases that are medically appropriate.
Kim, you bring up a great point. When you look at other fields, you look at orthopedic surgery, you're going to have orthopedic surgeons within a group or in competing groups. Some are spine specialists, some are hand specialists, some are knee specialists, but they have a free flow of patients because they're all busy. Everyone's busy. Everyone has enough business. Somehow in the cardiovascular world, that we haven't reached that level of, and orthopods have big egos, but they all have their niches and expertise. So, in the vascular world, there's aneurysm specialists, there's carotid specialists, there has to be CLI specialists. There are, but I don't know why we can't climb that hurdle or overcome that hurdle.
I don't either, and I hope for the patient's sake that we can overcome that hurdle. And you bring up, you explain that in such a powerful way, in that in every single practice, people specialize. And you even have podiatrists that specialize in sports. They don't specialize in diabetic feet. And so if everyone can just own where their skill set lies, there are enough patients to go around. And we have patients that are waiting for months, if not years, in Canada, years, to see a vascular specialist. There aren't enough to go around at this point. And so if there are people that specialize in certain aspects, let's give up the patient to those. Let's refer the patient to those doctors who might specialize in those below the knee and foot arteries, because it is a very, very niche, very special group of doctors and clinicians that I truly, in my heart of hearts, believe that you're putting your life on the line for these patients, because the exposure to the radiation during those procedures. And there are some doctors that I've been in their cath lab, and they'll say, if we can't get through in 45 minutes, give up the patient to a surgeon, we're going to amputate. But these specialists, these CLI fighters, critical limb ischemia fighters, this niche group of doctors, such as yourselves, such as Dr. Phillips, such as the doctor that we have also helped Deborah get to, you're sitting there and you are exposed to radiation sometimes for hours and hours and hours on end, as you're slowly trying to eke through some of the most complex lesions in these arteries with your commitment to restoring that blood flow. And you guys are truly, truly heroes.
Well, we appreciate that, and you bring up a really good point, and it's becoming a fear. I mean, our radiation exposure is astronomical. It's multiple doses higher than the recommended. I get the warnings all the time from the hospital about my exposure to radiation, and I'm probably one of many, many interventionalists. So there are risks with it. But it's why we're all passionate, because this is our mission in life, like yours is, to fix this.
And it's amazing, and they're actually by leaps and bounds, innovation is happening in the space to try and protect these doctors. There are even I know that there are some robotics that are coming into play. Can you imagine sitting in a control room and using a joystick to actually maneuver the wires and catheters and balloons through the artery? Have you done it yet?
I have not, but I'm super excited to see where we go with this. And I know that a few folks that have been involved with it, but yeah, it's exciting.
They actually have the realistic, I've felt it, they have the realistic biofeedback. So you can actually, the haptic feedback, as if, when you're pressing on your phone and and you feel that buzz, that you hit a number, same type of thing as the wires touching the plaque. It's very cool. I was at a university that was experimenting with it, and so I had the opportunity to see what's new and next into the future. And so I think could help increase the number of doctors that are out there, because I do think that some of the doctors that are arguing for their own limitations are also trying to and not doing these procedures and saying it's not possible to treat below the knee and into the foot. I think that they're also scared. I think that some of them may be scared for their lives, that they just don't want to put their life on the line as all of you are. And so, but it's amazing to the pioneers in the space, such as yourself, who are risking your own life for the sake of other people's life and limb. So I do want to move on there, though, to a couple of questions, because it's the Saturday and I know you want to get on with your Saturday. So we appreciate you being here. I want to get to Douglas. Douglas, you have a question for Dr. Mannava.
Yeah, so let's walk back to the beginning. So I don't know Kim. I'm not a nurse practitioner. I'm having these symptoms. I walk into a doctor's office. Are there things that in the very beginning that I can look? Because, I mean, so if I see my doc, I wasn't diagnosed with PAD till like the 6th visit. So now that I would have never known what this word meant. You know what I'm saying? So it's like, are there certain things that we know now that we can look for to say these words to a doctor who may never have thought about this?
Good question, Doug. Thanks for being on. One, when you meet with the doc, they've got to look at your risk factors, and they got to hear your story and your symptoms, and they put those together. PAD should start bubbling up the list, to really investigate. And it's simple things like Dr. Phillips and I were talking about. Simply putting their hand on your foot to feel your pulses it should be a standard of care when they examine you in the office, whether it's a primary physician, a podiatrist, a cardiovascular doctor, whoever it might be. And then, you go from there. So if that's abnormal and you've got the risk factors, there's easy tests that are obtainable, and then you can kind of proceed from there. Does that answer your question at all?
Is there a difference you can tell between PAD and what you're talking about?
Popliteal Artery Entrapment Syndrome.
As a client today, is that something that I need to think about, that I might need to bring up to my doctor? Have you looked at this?
Gotcha. If you've got the risk factors for regular old PAD, I think that's the path I would go down. If you don't, and you're younger, 50 or younger, then popliteal entrapment may be something to consider. Again, that's typically in those folks without any of the other risk factors, typically.
Yeah. Thank you, Douglas, for your question. Any other questions for Dr. Mannava? We do have one in the chat just about the difference. Can you have both of them? And you were mentioning it's rare to have both of them together.
I was told when I was a medical student, a patient can have as many diseases as he or she pleases. But it is rare. For some reason, popliteal entrapment, in my experience, is more, it's separate. Almost rarely do those patients have PAD. They typically have had healthy arteries.
An Angel, for you, it's interesting that we won't name any names, but you did have a call from your cardiologist afterwards, who heard that you were that there was this popliteal artery entrapment syndrome. Yes. And what was that conversation like?
Yeah, he called me yesterday. He was surprised by
the diagnosis, but at the same time, he was not surprised because he said he did know that there was an occlusion, but they had just went right past it when he did the angiogram. So he definitely wanted to speak with Dr. Mannava about that, and was trying to get in touch with him. But he called me personally and, let me know that he wished me luck and I can come back and see him if I need to. But I mean, I've had all kinds of diagnoses on my chart. It's been peripheral artery disease. It's been peripheral vascular disease. It's been the microvascular. It's been the small artery disease. I mean, I've had the Raynaud's. I mean, there's just so many different diagnoses regarding this that anyone can go on to. If you look in my information, you're going to be like, this girl has everything at 43 years old. I mean, and it was just easy just to throw something at me. This is the diagnosis she has, and go away.
And so when someone throws a diagnosis at you, what do they say in terms of, well, aren't you going to do anything? Why are my symptoms progressing? And I would imagine with peripheral artery disease, they would have said, here's take an aspirin, maybe a statin, and go walk, and you'll grow collateral vessels and you'll be fine.
Right. And they didn't say any of that. It was just, here, take this medication and go on with your day. But why? I am that person that will say, why? And it is very important that anyone who has these symptoms, that they advocate for themselves. That's all I can say all day long. Because if you don't advocate for yourself and you don't know, then you're just going to think. I could be walking around right now like, okay, well, I'm probably not going to have a foot in the next 12 months because I still have the lesions and the ulcers, because I'm just relying on what the doctor said. And
I want you to look at that. We're actually watching her walk right now.
I know.
This is amazing because she was literally just a couple weeks ago. Kim, I'm on an e-scooter. I can't even put pressure on that foot. I'm so in awe right now that you're literally walking around as if there's no hesitation.
Yeah. And the thing is I kept going to every doctor I would go to. I'm like, this is infected. Like, there's infection. And all they would do, they would feel my foot and they'd say, well, it's not warm. That can't be infected. And I'm like, I have a 0.41 digit index. Like, I have hardly any blood flow going to my foot. Of course, it's not going to be warm. And then once I was in the hospital, I said that again to the hospitalist, and she's like, well, it's not warm. It can't be infected. And then it came back, there was cellulitis in my foot. So they'd put me on some IV antibiotics, and it's still, it was deep in there. But no one would listen. Well, it's not warm. But it's angry, it's red, it's swollen, I can't touch it. But because it's not warm, you're going to tell me that I don't know what I'm talking about. As the patient whose foot I can't touch it, they just would not listen. And it's just, it baffles me that all of those physicians they absolutely disregarded anything that I said about myself, and that I knew what was happening with myself. I know I wasn't crazy.
Well, it's interesting, Angel, because you're in the healthcare field. I mean, you work for I would think we left that out, right?
I work for hematology and oncology. Yes.
Wow.
Yeah. So my hematologist, I contacted one of my hematologists, and she has been very helpful with me. And I went and seen her. I had a consult with one of my physicians, and she's like, so they put you on long-term blood thinners? Did they tell you why? I'm like, no. Like, no. So she's just as baffled as I am about it. Yeah.
What do you do? Are you a clinician? Are you in the front office?
I am I'm a supervisor for the central services scheduling and making the new patient appointments and things like that. So, yeah.
Wow, well, actually, that office is very lucky to have you because based on your experience, I mean, you really have that additional empathy for the
Yes,
patients that are
absolutely.
calling in.
Yeah, absolutely. Like you can't teach people that. And that's what I say when I interview, my staff. I'm like, we can't teach you the empathy and the passion for working in the healthcare field. I mean, that's something you have to come in to it with, and Dr. Mannava has that. Very grateful for that. And I was grateful that I was not like sedated, because it was so bright to see his face when he actually seen it happening. Like, I'm glad I was able to see that.
I'm curious, Dr. Mannava, would you describe that moment, that look on your face that she's talking about? And why? Why was it such a moment of excitement for you?
I think my eyes probably got really big, and I turn and look at my tech and my nurse, and I'm like, did you just see that image where it was just so obvious? I mean, it was like a home run diagnosis. So yeah. And we most of our patients are awake for our procedures. And so to be able to share, hey, this is what we're seeing, and to participate together in the diagnosis is really special. So we were able to immediately tell Angela, and I could see her like, yes, finally, I have a diagnosis. I'm not crazy.
Did you have that confidence going into the procedure? And was there any fear on your part being the doctor going, oh God, I don't like to find things, but kind of hope I find something and kind of hope it's what I think it is, because if it's not, oh no, what am I going to do?
Well, I like to find stuff. If I don't find anything completely normal, then that's frustrating, right? Then you're scratching your head. Well, what is causing your symptoms? So I'm always hoping to find something because I like to fix things. So, for me, no matter what it was, I was hoping we'd find something.
Something that's fixable,
Yeah.
something that could explain those symptoms, because um, it's good that you don't just go in just simply to go in. That's where you don't want to kind of not find something and have gone through and put a patient through um an angiogram and having the contrast fluid pumped in and this and that,
Yeah.
if you
And
don't have
actually
to.
it's fun. And Kim, when we first shot the dye through there, it looked completely normal. It looked pristine. And I'm like starting to be like, oh no, this is, and then we did her foot maneuvers and bam, it was so classic. So yeah, at first I'm like, oh shoot, this is negative.
Yeah, that could be a little frustrating, but I've been in some procedures around the world. My favorite one was in Nancy, France. And the doctor, and I have it on video. I wish I could show it here. I've shared it in the group a couple times, but where it was like, yeah, and they all started dancing and they high-fived and they were so excited that here's this patient that they hadn't been able to get through multiple times, and they just kept bringing the patient back going, come on, we're going to be able to get it this time. We tried coming down from the top, we're now going to try and going up from the bottom. Okay, let's try and go back again. We really don't want to amputate this patient, because in this one case, they were on the younger side, they were in their 60s, and so they still could have had a long life to live afterwards. They want to be on their feet, not trying to learn how to walk again. And they ended up with this newer technology they got to try, so they brought the patient back, and it was just like, oh my God, and they danced and they high-fived, and it was beautiful to see. And so doctors get really excited, right? It's good for these patients to hear that you get really excited when you're able to fix things. You don't want to wake up the patient and tell them bad news. We can't do anything to make you feel better.
Yeah, absolutely. I mean, yeah, internally extremely excited, but I'm an avid golfer, and so on the golf course you're trained not to show too much excitement, and you just play it cool. So that carries over into our day to day. We try to act like we've been there, done that, and we don't want to get too excited, just like on the golf course.
And Dr. Mannava was very, clear about, there are risks with this surgery. And, like at this point, it's, yes, I know what the risks are. And they're serious, they're very serious risks with the surgery that he's going to do. But I'm like, how many people have you done this on? He's like 6. I'm like, okay, woo. But like, either way, if I don't get it done, I have no quality of life. I'm not going to have any quality of life because I'm going to have these ulcers on my feet and I could have my foot amputated, or is it going to be my leg that's going to be amputated? So it's like, I'm going to take that risk because I believe in him, that he can fix it for me.
And this is one of those things, one of the questions we tell, patients to ask before any procedure is, what is your volume of cases? And, do you do a high volume of these? We were talking earlier about that, different practices, they can specialize in one thing over another. And while they might be okay doing a procedure, if they're not doing it quite a bit, then you might want to find a doctor that does it a lot. But in this case, and you don't have doctors that are doing this all the time at all, because it is so
No.
rare and, in my opinion, undiagnosed. So finding a surgeon that just has a really great surgical skill set, such as yourself, is critical.
Yeah, I mean, you can go an entire career, and I was telling Kim this, as a vascular surgeon, and see this only, 2 or 3 times. So it's not like anyone's out there has done 30 of these. So it is underdiagnosed, but it's funny, just in the last 6 months, I think you'll be my 4th one or 5th one. So I don't know, for some reason, once you start doing something, somehow patients find you.
And it's so true. I get one patient in one area that is a real critical case, and we focus on it and focus on it and focus on it, and then suddenly I get 2 or 3 more in that same area. I'm like, doctor, sorry to bother you again. Doctor, sorry to bother you. Doctor, I have another one for you. So it just becomes one after another. And with popliteal entrapment, artery entrapment, this is interesting, is just Angel wasn't my first one, but there was another one right before Angel, that was in Europe, and this patient came to us, and we were able to we had a doctor that's in our network, Dr. Lorenzo Petrone, who they'd already done a bypass on this patient and said that she had PAD. They did a bypass on the patient, and the bypass went down, and we were able to facilitate getting her to Dr. Lorenzo Petrone. And he was like, well, that's not even PAD at all. Go back to surgery and tell him it's Popliteal Artery Entrapment Syndrome. And so that patient was fixed because of that, with the right surgery at that point. And then right after Angel, I ended up with an 11-year-old, actually 2 young ones. I don't know how old the other one was. I think she was, 13 or 14, but an 11-year-old definitely, and a 19-year-old. And then the 19-year-old was a male athlete. And so in both cases, they were just told, you're too young to have PAD. And so it's just nothing. It's just in your head. Oh, it's just growing pains. And so thanks to Ken Slaw with the Society for Vascular Surgery, in both cases, we were able to get them to a popliteal artery entrapment syndrome expert, someone who's really passionate and focuses on that a lot, one in Michigan and one in Colorado. So it's interesting that everyone tells me it's rare, but then we get a whole bunch of cases that make me think, is it really rare? I'm not sure.
I mean, I question that as well, because I don't believe, I would have never known that I have this if it hadn't been for my foot pain. It wasn't up in my calf. Like everything that I read about it, it's like you'll have claudication, you'll have the calf pain, you'll feel like you're having a Charlie horse. I didn't have any of that until my toes would go white. And then I started having cramping in my foot. I've only had cramping in my calf a handful of times. So I mean, there's everything just goes back and says calf pain, calf cramping, calf claudication. But I didn't have any of that to where I would say there's an issue. So I think finding it in my foot is a little different than the norm, I would think. To find out that I have this by my foot instead of my calf.
You know, you bring up a really good point, Angel. It's sometimes a tricky diagnosis to make unless clots have formed and lodged in the foot arteries, like in your case. To have it in a young person who maybe is athletic and they just get some cramping, maybe during training for a sport, you know, oftentimes it's viewed as muscular or, you know, whatever it might be. So it is not an easy diagnosis to make when it hasn't progressed to the stage where you have it. I had a 15-year-old, he was a star running back for his high school football team. He came in with color changes to his foot like you did, and he threw clots to his arteries in his foot, much like you. So imagine getting a 15-year-old through an adult hospital system, navigating all of that, getting him for his testing, his angiogram, his having to deal with legal in the hospital, and all this because of his age, and the hospital typically doesn't treat pediatric patients. So that took a lot of me pounding the pavement to get him done, but he wound up having popliteal entrapment, had the surgery. I also had to operate on his foot and surgically extract the clots directly out of his foot. I think I worked on 3 or 4 or 5 operations. But yeah, he's in business school now and he's playing basketball and but yes, it's a tough diagnosis to make sometimes until it presents in a severe form.
Yeah, and those, go ahead.
And it is, I mean, I know that I'm still going to have, you know, possibly, or am going to have another surgery due to this, because there are clots that are still forming and going to the arteries in my foot. Like, I'm probably about 100% certain that there is another clot in the one that you did take out. So it's already done its business again. And I started feeling that yesterday with like cramping in my foot again. And I was like, oh man, like it did it again. But just to think all the time, constantly, about being able to walk and the pain and being able to go to a store and all of this, it's like, it's so draining. And when nobody listens to you, you feel like you're crazy. You feel like you have nowhere to turn. You feel like you're out of options. And I am very thankful and grateful for all of you guys to like just absolutely just listen to the people that don't have a voice anywhere else.
Yeah, it's interesting. When you found the Global PAD Association, you were at your wit's end. Was there anything that we said that gave you that extra, push to go and just keep going, to give you hope, or to give you any sort of guidance as to the direction?
I was putting pieces together myself. I was going in my chart. I was looking, I was like, okay, this was abnormal and this was abnormal. And, one doctor said ulcer. The other one said something about the arterial. So I'm like, okay. So then I am like, okay, arterial ulcers. So I'm putting that together. Shelby, stop, please. I'm putting that together. And I'm like, okay, so I have arterial ulcers. So I go to wound doctors. I go to podiatry, and they're like, why are you here? And well, you need to get blood flow to your foot. I'm like, you're telling me, it was me pushing and pushing and pushing and pushing and putting in pieces together and referring myself to everywhere. When I went and seen the cardiologist, he said, well, who referred you to me? I was like, I did. I'm like, I referred myself to you. I'm like, I can't get any help anywhere else. And he's like, I'll do the angiogram. And so he immediately, you know, went to work doing that. And definitely knew it was vascular after he did the original angiogram. And when my foot, he did those, the flexes, and the blood flow would stop. So I'm like, okay, now I need to find a vascular doctor that's going to actually listen. And then we found Dr. Mannava. So
yeah, it's amazing how you put the pieces together and found him. That's absolutely incredible. And we're very lucky to have you here, Dr. Mannava. I don't want to take up your whole day. We could talk to you for ever and ever, and I have always a million questions, you know, for you. So, but we respect and we appreciate your time, and we would love to have you back for our What's Up Doc Tuesdays to field all kinds of questions. And then we have every patient has a chance to come at you with a million different questions. And so you can pick any Tuesday that you'd like, any time of the year. We have a Calendly we can give you, and you can just pick one and come just for an hour. We just ask that you spend with us, and it's great to answer questions. And I'm sure after this and after Angel posts in the group that you're her hero, you're definitely our hero as well. And we appreciate you for everything that you're doing.
Well, thank you guys, and thanks Angel and everyone else who's come on and shared their stories. I'm passionate about this like you are, Kim, and so yeah, I look forward to it. If I can help out in any way and participate in the future, let me know. And obviously, I know John, so John and I have a great relationship. So, but thanks again for having me on. It was a lot of fun, and Angel, journey's just beginning for us.
Yep,
yes,
it sounds like she's gonna get back sooner rather than later. How quickly do you get these types of things, you know, scheduled when it comes to, you know, especially when you do have your own, you know, private practice and you are working on that ambulatory surgical center, I would imagine, right? Do you have that yet, or you're working on it still?
We're about 3 weeks from opening our doors for the surgery center. So, you know, this is something I plan to do in my surgery center in the future and have a patient not even have to set foot in the hospital. But in the meantime, we got to go through the scheduling hurdles and get her scheduled at the hospital. So we're trying to expedite it, but you know how that goes.
Oh yeah, definitely. Well, we really appreciate all you're doing. We hope to have you both back when she is permanently back on her feet and hear the rest of the story. We really appreciate your time. Thank you everyone for joining us here for our very special after show. You know, it'll also be available for replay. And if you do have questions for Dr. Mannava, go ahead and you can email them to Kim, KYM, at thewaytomyheart.org. And you can also, if you're in the Ohio area and you want to learn more about his practice, you can go to your website.
ViveVascular.com. VIVE vascular.com. So happy to field any questions in the future. If anyone ever wants to reach out, I'd love to be a resource.
Fantastic. And everyone, remember, the advice and views offered during this program are that of the guests on this program. Make sure you do get explicit consent from your own healthcare provider before acting on any advice or information offered here on this program. It is only for informational and educational purposes. So always, always, always check with your own healthcare provider before acting on anything you learn from here. And that being said, thank you so much, everyone. I hope you have a wonderful 4th of July. You know, I guess next weekend is the 4th of July holiday weekend, but I know a lot of people who are getting an early start, getting on the road, getting on the plane, and getting out those fireworks only where allowed. But be careful. Get out of the heat if you can. Wear that sunscreen. Hydrate, hydrate, and hydrate. Those are some words of wisdom as we